Okay, so our homework was to watch Secrets of the Shoulder by Gray Cook and Brett Jones. So this DVD was done back in 2006, so it's been quite some time since this was filmed, and I want to take some of the awesome information that helped take me to where I am and just start to elaborate on what I've learned since 2006 and just take that Secrets of the Shoulder a little bit further. So in that DVD, they do a good job of showing what we actually screen out here in our gym for the shoulder mobility, and they also have some breakout screens that are going to help. We're going to cover those, plus I'm going to cover a couple other screening assessments that we have here that aren't covered in that DVD, that we've had tremendous success with, and we need to make sure our clients have a certain level of functioning capability before we start to train and challenge them. Because somebody coming into our facility, we use the FMS, that's our initial screening tool, amazing tool, and it lets us get our job done. But like with the shoulders, if we see a 3 or a 2, symmetrical 3, symmetrical 2, not all the time are they cleared to overhead press. There's some stability issues. They may have unstable scapulas. There's a lot of things that could prevent them from doing a safe and effective overhead press. Or they're just scared. How many people are actually afraid to get a weight over their head because they're uncomfortable with it? So I want to elaborate on the Secrets of the Shoulder, as well as just what we do, what we've learned since 2006. So some of the screens that we do the FMS. So the FMS, what we look at is feet together, hands out to the side, thumb inside. We measure the palm, and that gives us what we measure. You reach, and we see how far the distance is between those 2 points. So understanding the FMS, if we get a score of 1, basically that gap is more than 1.5 hand lengths. That's what we consider to be a red light here. At that point, we know their mobility is restricted. We need to understand what's creating that mobility, because a lot of the times it's more than just the clenohumeral joint. A lot of the times it's going to be stiffness through rib cage, thoracic spine, and it could also be in the neck and the cervical spine. So thinking of the shoulder is a lot more than just thinking of one joint here. There's a lot of stuff that's going on, basically rib cage up, that can affect the performance and the health of the shoulder. So I want to make sure that we have specific screens in place. That way, let's just say we do get somebody that has a 2 or a 3 on a screen, but they're not comfortable going overhead. They have winged scapula, so we know they're not stable even though they're scoring this. We need to have a couple different screens and a couple different strategies to make sure that we can fix this. So let's start with our screens. First, the FMS screen. So our FMS screen, I just demonstrated it. It's where standing, feet together, thumb inside, reaching out, and we see how close we can get. We measure the 2 distances. Basically, we're trying to see if the acceptable range, 2 or 3, is if they can get within 1.5 hand lengths. So we just measure that. If they can get within 1.5 hand lengths, they would clear that screen. So that's our FMS screen. The next one, what we want to do is, it's part of the FMS, but there's also one more pain clearing test that we can add that's very easy to see if there's any impingement that could restrict them from training. So we've got the one in the FMS where you put the hand on the shoulder, basically heel of the palm on the collarbone, cross to the center line, and then we raise up. If there's any pain associated with that, right or left, we know, 1, we score them as a 0. We know we're dealing with a hot shoulder. So that's not something we should really be dealing with. That's something where pretty much automatic referral. We got Jake right next door. He does an awesome job with shoulders, hips. He's kind of our go-to guy as far as fixing that stuff up. So we need to make sure that if we do test a hot shoulder, we refer out, because it's just going to help the client get results a lot faster, and it looks good on our part. The next one that's very easy to add, so we're already doing this one, you could easily get here and just go across the body. So if you do have any AC impingement, a lot of the times just going across the body, that's going to flare that up too. So sometimes it's very easy to do. Lift the elbow, then you can just say, hold your arm out, and then just pull their arm across. Does that hurt? Does that hurt? And those are just two good screens you can check out to see if you have any impingement on that side. I talked about it's more than just the shoulder. So it looks like we're just kind of looking at the shoulder. We need to be able to also screen out cervical. So we're not chiropractors, we're not grabbing heads and doing passive, but we can do an active cervical range of motion test. So the active cervical range of motion test is, I would like to do it standing. Again, just like we do with pretty much all our screens, feet together so we know we're there, and then the teeth closed, or you can go tongue on the roof of the mouth, don't really care which one. Just look to the ceiling. They should be able to get a big look to the ceiling without necessarily needing compensation. And then also, you should be able to tuck your chin to your collarbone. If we see any restriction from here, or if they look up, they only get here and they're not able to get adequate extension through their neck, we know there's going to be an issue in the cervical spine. We don't deal too much with cervical spine. That's Jake again. So he can go over and clear out mobility in the cervical spine, and next thing you know, we can get better, restore breathing better. We can restore shoulder function a lot better, just because we did a little bit of work on our end, did the proper referral. That's one of them. So we got flexion extension. The next two I like to look at is I like to see if bringing the ear to the shoulder and just kind of seeing if that's symmetrical, or if they do this and they have to start to compensate and move their body, they have no lateral flexion. Then the last one I like to see is rotation with flexion. So you turn, you should be able to look over the shoulder, and you should be able to flex down and get your chin to your collarbone. So basically there we're just looking, are there any gross asymmetries right and left? Do I look this way and then this way I can get all the way over here? If we see a big asymmetry like that, just through an active range of motion, best place for us to start is going to be with a referral. Just make sure that you explain it to the client. We'll be able to get a lot of further progress quicker if we use the referral. The next screen that I like to use is, can somebody give me just a half piece of foam? This one's going to be our seated T-spine rotation. And Nick, while you're over there, can you get a PVC pipe too? I like to use a little lower chair than this, but basically you go from a seated position. My feet would be together. Doing this on a chair works a little bit better because my feet can be flat on the floor. But I would just be here. I want to make sure all the motion is going to come from my torso and not necessarily come from sheeting and actually rotating my hips. If I get my thighs between here, my feet together, I'm going to be able to get a good idea of where we stand with rotation. So getting in this position, you should be able to rotate nice and tall to about 45 degrees. The biggest thing we're looking for is going to be compensation, stop them where they compensate, and just primarily looking for, can they get close to 45? If they can get close to 45 and they're symmetrical on here, some of our mobility work's going to work. However, if we got somebody that's getting to 45, 50 degrees and then bam, they're jammed up at 10, 15, we're going to get a lot faster progress if we just go ahead, use Jake for his skills to clear that up. Next thing you know, we're dealing with more mobility. He'll do his proper job of giving, the corrective exercise selections to help make it stick, and it's just going to make everything we do more effective. So we've got our shoulder mobility screen, our pain clearing tests. We've got we want to check out the neck. So flexion, extension, lateral flexion, and then rotation with flexion. And then we've got the seated rotation. So everything beyond the FMS, like if we score 1, this is a perfect time to start rolling through all these screens to find out exactly what we're dealing with. If we got a 2 or a 3 on there, that's just going to be whenever we notice like unstable shoulders, they're not confident being able to go overhead. This is where we can use some of these assessments to make sure that they are safe to go overhead. The next screen I'll cover is the overhead reach. So the overhead reach, I like to get my back flat against the wall. I would usually step out in front, give a little squat, and I want my low back to be flat in the wall. My entire spine would be up on the wall, and basically what I'm trying to do is trying to see if you can reach overhead without needing compensation through the low back. So if you get nice and flat, everything flat against the wall, you should be able to at least get that tricep past the nose. I look for, can you get your thumb to the wall? If you can get your thumb to the wall without compensating, that's going to be a good clearance, because now I know you can actually get your shoulder in a good position without compensating. So if you can clear that one, then I want you to be able to clear that before we actually do anything overhead. This is probably going to be the biggest one to check out here, is going to be breathing. So we've got breathing by position. They did a good job of talking about breathing in Secrets of the Shoulder, but you guys all know the importance of breathing, and we need to just elaborate and make sure that we go over the breathing aspect a little bit more in depth. Guys, it's pretty safe to say that 95% of the people come in here have dysfunctional breathing. You know, everybody's breathing from their neck, their shoulders, everything's all up in here. If we know we're breathing up in here, we're creating a lot of the times you're going to create a lot of dysfunction going on throughout the rib cage, the shoulder, and the thoracic spine. So we need to make sure that that breath is coming in the way we want it to. So a good way to do that is to just go into the crocodile breath. So a crocodile breath, we would just go on our belly. Actually, let me coach somebody through this. Somebody come up here and go on your belly. I'm showing crocodile breath, so go hands on your forehead, on your hands. We get the spine in a nice long position, and what I'm looking for is 360-degree expansion. So the crocodile breath is great to see if you're getting air in the belly. I'm looking to see if air is coming in from here, or if air is coming in from here. As I'm going through this one, can you go ahead and give me a zoom? Mm-hmm. So what I'm trying to see here is, give me a bad breath in here. Whitney, breathe up in the chest. Exhale. Yeah, that was kind of a good one there. That's a little worse. So I'm looking at, where does this air initiate? Does her chest rise first and her back, or does her low back start to rise? So if she's breathing properly, I should see this low back rising because her belly is pushing into the ground. One big aspect where most people lose out is, a lot of people understand the importance of breathing from the diaphragm and breathing from the belly is 360 degrees. You have to be able to breathe 360 degrees, otherwise if it's purely belly, you just end up taking a bunch of belly breaths, all that air is pushing in here, increasing the lordosis in your low back, exaggerating rib flare, decreasing mobility through the shoulders, and breathing is going to be out of sync. So from here, I need to make sure the low back can rise, but I want to drive my fingers into the side and see if I get anything into the sides. If you're not getting anything into the sides, I know that it's going to be purely front and back. You need to be able to get like you're filling up a weight belt. So I want to just basically feel, can she get air into the sides? Can she get air into the belly? Can she get air into the low back? Is it filling up like a belt? Or is all that breath coming in up here? A lot of manual touch is going to be able to fix this. As we get into our corrections, I'm going to go through a couple breathing things like our silent breathing and our 4 steps that we do to encourage this 360-degree expansion. But that's one screen. So Crocodile is a good, easy one. However, I like to screen this out in multiple positions. So let's just go seated on the edge of the table. Yep. So I could do this in a kneeling position, like just hang yourself. I could do this in a kneeling position. If I was wanting to train standing overhead, you better believe I want a good breath before I start to train in whatever position I'm doing. So let's just say I was doing it. We don't really do a seated military press here, but let's just say that's the exercise I chose to. We're in a traditional gym and we're doing a seated military press. I would want to just check breathing. In this position, again, I would check breathing into the sides. Like, see, we went seated. She's doing not as good in a seated position as she did Crocodile. She was getting air into her sides here, but now air started to go up into her chest. So it's like, in this position, Whitney has a tough time breathing. In this position, is it smart to start to train this harder? I don't really think so. Until we can actually dial in a breath first, the most basic function, whatever position we are, whatever position we're trying to train the shoulder in, we should at least be able to see if they're getting 360-degree expansion. If they're not, I know the core's not doing its job, and that shoulder has a chance to become unstable and get injured throughout the process. So that's basically the 360-degree expansion. You go whatever position you want. Usually if I'm just screening it out, I'll usually just go on the therapy table or on the floor and just kind of see where they're at Crocodile. If they can start to, if I know it's a dysfunction there, I usually know the breathing has some sort of dysfunction. If they do good there, like Whitney did all right in the Crocodile breath, that's why I would want to try the 360 expansion in just a couple different positions to see how I'm going to program for her. You know, it's like I might train her shoulder a little bit differently because closer to the ground, she has more stabilized breathing and core support than whenever gravity starts to take effect and she's standing. So that's our 360 degree. Go ahead, stay there. There's two more screens that I want to just talk about. So the last two, this is also a breathing one. Just go back down to that like crocodile breath. So along with a 360 degree being able to get air in here, basically the lungs need to be able to fill too. I'm going to put her in this position and I'm just going to see if she can actually get air into this position. You should be able to get air into the back of your lungs and not just the front of the lungs. So this is the posterior mediastinum. If you can't get air in here, what happens is the T-spine typically becomes flat. So we have this nice good kyphosis that we're supposed to have in our T-spine. If you start breathing improperly, a lot of the times that T-spine becomes very flat. And if we lose that position, that natural kyphosis to where the shoulder blade kind of sits on and gets its stability from, next thing you know, that starts to flatten out and that scapula becomes very unstable and it's just kind of hanging on to nothing. So if Whitney's not able to get air in here, which I know she's not going to be able to because this is one of the correctives we're working on with her, then basically I can see her T-spine is starting to flatten out and that's why she experiences a little bit of shoulder impingement. So she's going to have to worry about that shoulder until we're able to reestablish some of this natural kyphosis again. And we're going to get that by being able to push air in here. There's a couple, so this is our posterior mediastinum test. Basically, I would just put one hand, I'm going to be like, breathe into my hand up here. And I'm just trying to see if they can suck air into that position. We can get into a position to where you're even reaching and seeing if I can suck air in up here so you can really separate it. but you can see if you can get it just like a crocodile breath. So I can check down here, then I can also check posterior mediastinum and be like, push air in up here. If it's completely dead, like I can already tell, I can see a flat T-spine. I know she can't push air in up there. I need to work on some breathing stuff to give her that natural kyphosis back and give her strong, healthy shoulders. And then the last one, in Secrets of the Shoulder, they talked about grip a lot. Grip is definitely overlooked and it's extremely important. So go ahead, sit up. So there's a couple ways we can check grip here. We can do, like they explained in there, we can do a finger grip to where I can just see where you're at left and right, or we could just do a hand gripper and see how close it is. We don't have a hand dynamometer that we use here to say, oh, I got 120 pounds on the right, 118 on the left. It's not that specific, but if there's a big difference and like one day they're able to crush you, the next day they come in and they can barely squeeze your fingers, kind of know their central nervous system shot. It's like almost kind of like a cheap HRV, you know, it's like I know what's going on with your nervous system by what's going on with your grip. You guys know we've been doing a lot of rock climbing, and I've seen that too. Is like I remember one day I saw her like pretty much falling off the wall, and it was because her HRV was pretty much down that day. And her grip showed it. So there's a big correlation between grip and nervous system. There's a lot of proprioception in the hand, and we need to make sure that we at least address grip, and I like to address it in like 3 different positions. So I would address grip here. I could just do, I'm just going to do a 2-finger, like I can have her squeeze here, almost like a handshake, and I would check right and left. I could have her do it both at the same time, and I can see like, is there a difference? Like her right is stronger than her left, so there's a little bit of a difference there. Which shoulder gives you issues?
It used to be this one.
So that could tie into it. So it's like I feel a little bit of difference. We've done a good job of clearing her up. She's not necessarily in pain, but we still have to get some more kyphosis, and I can see it right there. So I check here. I would also check almost like in a rack position for our kettlebells. So I would check here and see if there's a difference, or is it close to the same as if she was here. And then also I like to check overhead and see if that completely goes dead, because a lot of times they should be very similar here, here, here. If we go overhead, next thing you know, they have nothing, shouldn't be training overhead. So they may have the mobility to get up there, but they don't have any way to actively turn on. So grip is going to be extremely important. Make sure we assess all those. So just to recap some of our screens that we need to do for the shoulder, if you get somebody that we need to do a little bit more assessment than just the FMS, and you want to dive further into the upper thoracic region, shoulder region, we've got our typical FMS, hand reaching, trying to get at least 1.5 hand lengths. We've got our impingement. If there's pain there, that's a quick referral. Let's get that cleared up so we can, get them training in here. We've got our neck. So the neck needs to be able to move. So if we're not able to go through flexion, extension, the rotation with flexion, and then our lateral flexion, then we need to make sure that we have adequate range of motion in the neck. Overhead reach. So we did here. You should be able to get overhead without having to compensate through the lumbar spine. We did the breathing. So I did the 360 expansion, and I also did the posterior mediastinum, see if you can get air into your upper back as well. And then the last one just did is the grip. Check 3 different positions, and I'll cover a little bit more as we go through this on some of the correctives, like when to choose. So we recently changed our poster system, and it went from like 2 to 3 exercises. Now we have like 6 or 7. How do you choose the best exercises for somebody? Instead of just having 1 or 2 to fall back to, and everybody does like lowering with a straight leg raise. It's like some people it might work better to work breathing and pelvic tilts than it does with leg lowering if we're dealing with straight leg raise dysfunction. So I'm going to take some of these screens, I'm going to break them out further. We'll cover some mobility, some of our favorite mobility ones. So if we see somebody that's stuck through the T-spine, stuck and jammed up through the shoulder, cover some of that. And then we'll also go into some stability stuff to where somebody's loosey-goosey, you know, they're able to pretty much touch their knuckles together, but their shoulder blade, I can come by and just grab it. You know, it's hanging off their rib cage and they're afraid to do anything, you know, presses and pulls, just because they know that scapula is just hanging out in the middle of nowhere. And we'll cover some correctives to go over that. So this is like a further screening assessment that we can do, and just some breakout screens that we can do on clients if we think we need to, you know, find out what's going on with the upper thoracic, upper region here for the shoulders. So that's our screening and assessment.